Welcome to Empowered Voices, Recovery to Resiliency. I'm Amani Wilson, joined by my co-host, Dr. Farzad Kamyar. In this episode, we are going to talk about medications used to treat substance use disorder during pregnancy. Our special guest will educate listeners about medication-assisted treatment, MAT options, safety considerations, and how these treatments support both maternal recovery and infant health. We will address common concerns and misconceptions about medications and talk about the importance of medical supervision and individualized care. Dr. Farzad?
Yeah, thanks, Amani, and welcome to our guests. So we actually have two special guests today, both from High Risk Pregnancy Center here in Las Vegas and also up in Reno, across the state. So Dr. Brian Iriye, a maternal fetal medicine specialist, sometimes also referred to as a perinatologist.
Hey,
welcome. Could go on for the next 15 minutes about Dr. Iriye and all his accolades. I will just say, to keep it short and sweet, with confidence, one of our greatest leaders in the world of maternal fetal medicine and OB here in the United States of America.
Yes.
And in the country. So super honored and privileged to have you with us, Dr. Iriye.
Yes, we are.
We're talking a wealth of information, a subject matter expert across the board in so many different ways. Former president of the Society for Maternal Fetal Medicine, which is like the organization for MFMs.
Awesome.
Thanks for being here.
I really
Thank
wish
you.
my mom was here. Yeah.
Thank you for being
Thank
here.
And then also Dr. Manijeh Kamyar, also known as MJ, my significant other, but no
Yes.
relation to the purposes of this episode, maternal fetal medicine specialist as well, also at High Risk Pregnancy Center. Why do we have Dr. Iriye and Kamyar here? Because they are the boots on the ground specialists that are treating pregnant and postpartum individuals with opioid use disorder using the medications and the subject matter for this episode. Yeah, that we're going to be talking about. Super awesome that they're here. Welcome.
Welcome,
both of you.
welcome.
Yeah. We have limited time and we can probably talk about this subject for so long. Okay. So let's just kick it off and get right into it. Let's talk about this world of what, Amani, you mentioned, medication-assisted treatment, aka MAT. Now, I
Yes.
will say plug and sort of moving towards a more medicalized, inclusive term regarding those things, non-stigmatizing, and trying to keep it on level with other chronic disease management. We are moving towards a term called medication for opioid use disorder, also known as MOUD. But by and large, most folks still know it as MAT. So for the purposes of this episode, that's what we'll call it, okay?
Okay.
MAT. Dr. Iriye, get us started. What are some of the just give us the blanket overview of medications for opioid use disorder during pregnancy that folks can understand and sort of relate with.
Well, I think how a lot of people come to us, they come to us with an issue with the opioids and then other substances at the same time. And what we need to do is we need to transition them in a way that kind of gets them to a more safe and stable environment by putting them on different medications, which will kind of ease the way throughout pregnancy. The major two medications that are used are methadone. A lot of people probably know about methadone. It's a long-acting medication. It's been used for a long time in the United States and has been like the standard of care for generalized opioid use disorder. But in pregnancy, it's a little bit different. And over the last 10 years, we've kind of moved towards this treatment with buprenorphine for many reasons, which I think we'll go into later, also known as like Suboxone or Subutex. And that medication has been shown recently and actually as much as 10 years ago to be much safer during pregnancy, safer for the baby overall, to provide better outcomes. And so that's kind of where we're transitioning for, because you were involved in the initiation of our program, that we really felt strongly about that and moving it forward. And I think it's been pretty fantastic. And I think the outcomes we've been seeing are fantastic as well. So that's kind of the groundwork for it is hey, over the last 10 to 15 years, there's been a kind of understanding that this treatment is needed. And then also moving towards a treatment modality or a treatment usage that's safer for pregnancy and not a one-size-fits-all kind of criteria.
Yeah.
Love that.
Yeah, and you mentioned it. There's options, right? So there's options. So specifically, when we talk about opioid use disorder, 3 FDA-approved medications. We won't go into it in a lot of detail because it takes a lot of time. But methadone, buprenorphine, and then naltrexone. Actually, I think if you were to ask us at the end of the day, if we had the ultimate data to support it, both Dr. Iriye, Kamyar, and I would agree that if I could choose one, it would actually be naltrexone during pregnancy. But unfortunately, it takes a long time and a lot of data to sort of have that recommendation come down from major medical societies like Society for Maternal Fetal Medicine, ACOG, American Society of Addiction Medicine. So that's why, for all intents and purposes, we really talk about methadone and buprenorphine during pregnancy because there is that recommendation. Dr. Kamyar, can you tell us maybe, when we're talking about methadone and buprenorphine, are they safe during pregnancy?
Yes, both of those are safe during pregnancy. So people like to, ask questions about what does safety mean in pregnancy. Safety in pregnancy means that you can take it without worrying about causing major harm to the developing baby. When we talk about major harm, people think about anomalies, right? Anomalies just means if the body parts of the baby are going to grow normally. And those medications do not affect that. So whether you're on them before you get pregnant or you decide to get on them while you're pregnant, we recommend methadone and buprenorphine, especially over using substances like using oral opiates, using heroin, substances like that. So yes, it is safe in pregnancy. That doesn't mean there's absolutely no effect when baby is born, but they're definitely safe to use in pregnancy.
Yeah, Dr. Iriye, can you talk a little bit about what those effects might be?
Yeah, I think, I completely agree with Manijeh is that, safety in this context is kind of different. I think it's more safe, to utilize these medications during pregnancy. Some of the risks that you see during pregnancy that somebody might say, well, I don't want to be on those medications because there's increased risks. Like some of the increased risks are preterm birth or a baby that's a little bit smaller, or what we would call growth restricted. But I think those issues are much stronger outside of a program and on usage that's maybe over the somebody else's prescribed drugs or street medications. So I think when you look at that, we want to kind of push the narrative that it's a relative safety, but it's a way better way of going through it. And then I think we're talking about the physical harms of things too. I think we also have to talk about the mental harms of these medications and these street drugs in comparison to utilization of medications, because we just see awesome benefits on people within our program, and the clarity and the understanding of what's going on just come out, and their families are just so much more excited by the progress they're seeing. So, long story short, I think safety overall is one thing. I think you could say overall, though, with the opioids, there's maybe a mild increased risk of heart defects. There's a mild increased risk maybe of things like gastroschisis, where the bowel or the abdomen doesn't close. But those are very, very small. And I think it's much more important to talk about the beneficial effects and the mental health effects, which are really, really important.
Yes. I wanted to ask, I know it was mentioned that buprenorphine is a better option if you are pregnant. Let's say we have someone who is taking methadone at first, and then would you recommend that they switch over to buprenorphine, or is that something that's easily done?
I'll let Dr. Iriye start with this one.
Let Dr. Kamyar go.
Okay, all right.
He's looking at. He's so excited that you're here on the podcast. Well, what I would say is number one, it is absolutely something that can be done. It's not as easy as just saying it can be done, though. So it has to be done under really close supervision, but is something that if you are a patient who's already on methadone, you get pregnant, you hear about buprenorphine, you're thinking, wow, that sounds like it's a better option for me during pregnancy. you need to reach out to providers who can help. So you reach out to your current methadone provider. And then here in Nevada, I would say you would reach out if you're pregnant to our practice, because we will help you to do that. It doesn't happen overnight, but it is definitely something that is an option for patients. We look at patients as a whole. So we kind of talk to them about, well, how have you been doing on methadone? And if they've been having this like massive success on it, then maybe we decide that trying to make that transition is not the right thing, right? Even though maybe the effects, and even though we know that the effects with buprenorphine are improved for a baby, maybe because mom is doing so well on that current regimen, you wouldn't make that switch. But sometimes it makes sense to make the switch. So it's a really, really good question.
Thank you.
Yeah.
Thank you for
Dr. Iriye, you want to add anything?
No, I completely agree. I think, would we like to switch people? I think your question's a great one, right? Because if you have one medication, usually switching to another one's easy. It's kind of like an antibiotic. Well, do I take penicillin or do I take Keflex or something like that? Sure, I just switch over the medication. With this, because of the long-acting effects of methadone and a kind of an inherent or with buprenorphine, how it acts on the body, it acts both as an agonist or something that works on the receptor, but also an antagonist, which works against the receptor. You can get some problems theoretically more with withdrawal. So it takes us to have to look at people and put them into kind of special centers or observation so we could make this work well, or they have to be on lower doses. So that's when I agree with Manijeh, like wholeheartedly, that, the earlier you see us, the better it is, because we could work with you, make sure it's the right thing. And then they're probably on a lower dosage earlier in pregnancy, which makes the change a little bit better. So, hey, give us a call. That's what we want to do. We're here to help.
That is so awesome.
Yeah, I 100% agree as well. Amani, for our viewers and listeners, a very delicate procedure process, yes, specifically making that switch. So I would say you absolutely wholeheartedly need experts. I'm waving my hand for those that can't see, that can weigh those options, talk about the methods that we used to make that transition and whether it's the right decision. In all things healthcare related, yes, this is what I call a very patient-centered approach process, which means ultimately we can talk as much as we want, hours and hours and hours to someone about the different options, but that individual needs to make the decision, whatever decision they make, that is the best for them, yeah? So we sort of facilitate that navigation piece. And then if they do decide, ultimately weighing the risks, benefits, how they are doing, et cetera, then yeah, we'll be there to help. So like Dr. Iriye said, call. But, oh no, go ahead.
I'd add one thing, because I think we all agree with this, but we don't say it, right? Is medication is one part of therapy.
Yes.
But the psychological aspect is another part of the therapy. So medications aren't the only therapy. It's kind of the personnel that you have within your office to be able to talk to people, to help them cope through the tough times, to look for different signs of maybe there's more issues going on. And those are the things within programs in addition to medications, which make programs successful for patients.
I love that.
Yeah.
That makes 1,000% sense.
Yeah, absolutely. And a little bit about what you mentioned. I want to make sure we hit on this for folks that maybe don't understand how these medications actually work. Like when I take a blood pressure medication, what happens inside the body that the blood pressure reduces? There's different receptors that these medications go and activate, dilating your vessels, for example, causing the heart not to pump as hard. And then, the pressure comes down. These medications do something. Dr. Kamyar, can you talk a little bit about Dr. Iriye had mentioned, like buprenorphine works as an agonist, which sort of activates the receptor, and as an antagonist. That seems weird.
Yeah, it does.
Same thing at the both.
Choose a side.
Yeah. Both things at the same time, right? So, can you talk a little bit about, Dr. Kamyar, how these medications work?
Are you talking about how they actually?
Yeah, like
sorry, I guess
I'm
wondering what you're looking for.
Physiologically, what is it that they're doing inside your body? If you want to comment on that.
Well, what's happening inside what they're doing is replacing the the opioids that you would there's little receptors in your body, little opioid receptors, and if you take opiates, you take a pill or you use heroin, the medication those drugs go to those receptors and they cause some effects in your body. And what buprenorphine does is it kind of goes in those receptors and just is a placeholder in there. So it takes the place of opiates. So any receptors you have that are opiate receptors, your buprenorphine that you take or your methadone that you take goes in and it sits in that receptor. And it sits in there and it is very kind of strong. And it's a little bit almost, maybe that's not the right word for it, but it's potent. Yeah. And it sits in that receptor and it prefers that receptor over if you even use heroin on top of using buprenorphine. So let's say I take buprenorphine and then I decide, for whatever reason, I'm going to go use some illicit substances such as a heroin. When that goes in, the heroin is not going to attach to that opioid receptor because that buprenorphine is already there. Yeah. And the heroin can't kick off the buprenorphine. So that buprenorphine sits there. And so I've told my patients this in the past, and this may not be a very popular opinion or thing to say, but we've had patients that say, well, I used, you told me that if I use heroin after taking buprenorphine that I wouldn't feel anything. You wouldn't get that euphoric high. And they're like, but I needed to try it anyway. And I did. And you were right. And I'm like, yeah, I'm okay with that. It's okay that you tried it. I think it's not just the replacement with buprenorphine. It's the fact that it's the patients still have that craving sometimes to use, or they want to know what would happen if they do. And I never make someone feel like they did something wrong or bad for doing that. But that sort of explains why when they use their opiate or they use heroin, it doesn't really do anything. And sometimes just that kind of teaches that patient, hey, there was no point in doing that. And so now I feel like I don't need to anymore, I don't know if that's answering your question.
It actually answers it 100%.
And it actually really helps explain.
Yeah, and that's one of the reasons why we favor a medication like buprenorphine, right? Because of that dual properties. You effectively can't overdose on buprenorphine.
Love it.
If you mix it with things like high levels of alcohol or benzodiazepines, like think Klonopin, Xanax, then yeah, but on its own, you can't because it's so potent. And it doesn't activate, it's a partial activator. It doesn't activate the receptor all the way. You don't get what ultimately causes overdose deaths, which is suppressing my breathing drive, and then I stop breathing. That's what's killing people, right? That's what an overdose is. Full-on opioids like heroin, fentanyl, oxy, you name it, right? They go in, they hit the receptor, they hit it hard, breathing slows, stops. And it can only stop for so long before you die, and that's an overdose. With this medication, not so much. Ultimately, what these medications are good for is preventing withdrawal. Yeah, so they prevent withdrawal. They help with things like cravings and urges, and time to return to use, helping people stay in treatment. And those are all positive factors, which is why these medications are known to be life-saving medications. And there's such a strong recommendation that these major medical societies, including American Society of Addiction Medicine, in the world of opioid use disorder, they're so effective and they save so many lives that they have a statement that says treatment which does not include medication is actually not treatment. So there's the take home. Okay, there's the take home. All right, that's how important they are, and they absolutely need to be involved in every discussion we have with our patients involving treatment. A patient can choose absolutely not to take a medication, right? No bias, no judgment, no problem. We'll work with it, but that's how effective they are. So knowing this, right, Dr. Iriye, can you talk about when can you start, Matt? If someone's pregnant, maybe thinking about getting pregnant, when can they start?
I mean, I think the ideal time would be prior to pregnancy if you could, because you just want to get that stabilizing effect before pregnancy, and because you want to go into pregnancy with a clarity and working towards the purpose that you want, right? Unfortunately, though, 40 to 50% of pregnancies are unplanned, right?
Yes.
So you walk into these scenarios that are not rare; they're very common. Of wow, I'm on this medication and I'm pregnant. Well, at that point in time, that's when the team needs to be activated, right? You need the activation of the team that puts forward kind of the therapy that we talked about, that works with the medication, and then works with the obstetrical team to kind of make sure the team kind of knows, what the risks are, but what the benefits are. More importantly, the latter, the benefits, to basically, be putting their arm around the patient's shoulder and pushing them forward, right?
Yes.
And I think that, this team-based approach is a super important one because, one provider can't do it all, right?
You're right.
But many providers can provide kind of an overall kind of fence of care around the patient to create that fence of safety. And so that's how I like to look at it.
Yeah, I mean, you hit the nail on the head. I mean, we've talked about so many times other members of the care team, including, social workers, case management, care coordination, peer recovery support, your therapist, your family or close social network, whatever that looks like, is sort of being important. But getting back to the sort of this pregnancy, and now we're on Matt, effectively what I'm hearing is that you can start anytime, ideally before pregnancy. And if you're not on and you're pregnant, we say as soon as possible, even up to the day of delivery.
I've had patients start the week before. I've
before?
had patients
Really?
come in and we start them on medication and then they deliver a couple days later, not because they started the medication, but because they were already,
Thanks for
I'm saying they're already 39 weeks,
Yes.
right? They were already sort of getting to that point where they were going to. Some patients were actually looking to start treatment that whole time, but they had a lot of roadblocks.
Yep.
And we've talked about this before, Amani, where they had a lot of roadblocks and they weren't even ever able to find a provider. They didn't know we exist. They didn't know that there was a place they could go while they were pregnant that would provide them with buprenorphine because they've been told that there's nothing for them and they need to just keep using their opiates. Right?
And I think that's so important, right? I think what you just said is so important
Yes.
because, it's not easier after you deliver.
It's not.
It's harder. There's more sleep. Your living circumstance with an initial person is there.
Yes.
You have to wake up. You have to breastfeed. You have to go to doctor's appointments. So the stress levels are so much higher.
Yes.
And getting somebody stabilized ahead of time, even if it's a week, 2 weeks, 3 weeks, and into a program, is just something that kind of, I can't tell you enough that I think it's so underestimated. And I think, that's why that point is such a good one, right? When's the time to start? Anytime.
Yes.
Right? Anytime it's safe. And because there's going to be benefits, there's going to be ways of moving forward, there's going to be ways of improving outcome because you're in that kind of program.
Yeah, and Dr. Iriye, you had mentioned something. I think both of you had mentioned it, and we actually see this in the community. And so I really hope that we can continue working on education, informing clinicians and professionals, healthcare professionals, but also individuals so they can advocate for themselves. I'm going to say this with the utmost confidence. If you are told during pregnancy to continue using your illicit substances, including whether it's illicit heroin, fentanyl, that is not the recommended option. No ifs, ands, or buts about it. Give someone a call. If someone says that to you, go see someone else. Give Empowered a call. They will help you navigate and get you to a treatment program because that is not at all what we should be telling our patients.
No, because if someone's coming to us asking, what should I do? It's almost always because they want to do something else.
Different. Yes.
They're not asking, what should I do, hoping you'll say, keep on using your heroin. They're actually hoping you'll say, oh, this is what you should do, and here is how you can do it. Because that somebody coming to you as a doctor or as any kind of provider and saying, I'm wondering what my options are. That's the point where you have a chance to intervene in this person's life in such an amazing way. And for someone to be told, sorry, you're pregnant, there's nothing to do, but don't withdraw. So keep on using, right?
It's discouraging.
It's extremely.
And I think another point of that we have to make is that, there's this thought in the United States that there's this maternal death rate or maternal mortality rate that's so high, and that we're so far behind other countries or economically developed countries. And I think what we have to realize is it's different within states, but anywhere from 12 to 20% of all pregnancy-associated deaths are from overdose. And so when people are not in a program and they're told to do something beforehand, and then they get all those things that we just talked about, the increased stresses afterwards, the proclivity or the desire to use is going to be so much higher.
Yes.
And then you're going to get in these scenarios where overdose is a much bigger problem. And actually, that's at about that 6-month stage after delivery where a lot of that occurs. And so, start getting a program, be followed by people that really care about you, and work to kind of a better means for your family.
Can I bring up one thing that I've seen a lot just recently in my practice is patients who are really hesitant about being on buprenorphine because they don't want other people in their family to know. And so I just want to bring this up because a couple of things. Number one, we don't have to tell anybody any of your business.
Love
right?
it.
So definitely you just have to, come to your doctor's appointment and especially if you don't bring anyone with you, even if you do, we typically, sensitive material, we are not sharing with other people who are there. So I want to be clear that you don't have to tell anyone any of your business. It's your medical information and you don't have to share any of the medications that you're on. But what I would also add to that is that you would be surprised, I think, how many of our patients have eventually told their family members because they went through therapy and they had all the help and they were like, okay, now I'm ready, right, to talk to my family. And how many of those family or whoever their partners are actually supports really strongly the fact that they're on in a program and on MAT.
I love it.
So I just want to, I want to put that out there because I've seen that a lot in this last month. Just it's come up a ton. And I think it's really important to say no one has to know what medications you're on, number one. And number two, you'd be surprised how supportive your family will be.
It's funny that you mention that because a lot of the calls I get in for potential clients, that's a lot of what I've been hearing, especially lately, is I don't want my family to know. And that's how it was with me. I didn't want my family to know. I didn't know how to reach out, So I feel as though I think it's amazing that you guys do what you do. And I loved how you said pretty much like it takes a village. It reminds me of like it takes a village to raise a child. It takes a village to make sure one person is getting the whole full treatment needed.
Yeah. Mental health, umbrella, substance use underneath.
Yes.
Stigma.
Yes.
Right? Stigma.
Yes.
Family, friends, significant others, colleagues at work. I mean, there are a lot of implications with the stigma that faces. My analogy is always to another chronic issue like diabetes. If someone knew that you were on a diabetes medication, it's usually meh. Yeah, okay. So, me too.
Yep.
Yeah, me too. Yeah, feel free to share. But not so much when it comes to mental health treatment.
Yes.
I want to save time to get to sort of these, what are some fears, what are misconceptions, and hear from Amani. Maybe you can sort of, we'll get there. But I want to continue with what Dr. Iriye had mentioned. And he's basically, those are just facts. So Dr. Iriye was on Maternal Mortality Review Committee, as I have been. And that's just it. That's just the numbers. There's nothing going on in Nevada that is unique. It's representative of the country. By far and away, the single largest cause and reason for pregnancy-associated deaths, overdose. And it's not even close. And what we find, which is what you also said, was that postpartum time period is really crucial. And that's actually what we see as well.
Yes.
That the majority of those overdose deaths occur in the postpartum period. So along those lines, when someone comes in for delivery and postpartum care, what does MAT look like? Since it sounds like that is a very vulnerable time for folks.
Are you asking either one of us?
Either one, yeah.
So what I think you're asking is, what do we do? Do we continue? And absolutely. And we actually, a lot of times, the first time we encounter a patient who uses opiates is on labor and delivery. They show up. They came to the hospital because they were having the baby. They didn't had get any prenatal care prior to that because they were worried about all the stigma, or maybe they couldn't get or whatever, couldn't get to a prenatal care appointment. And now they're here and they've delivered and they are going through some withdrawal and they want to know if they can start on something. And the answer is absolutely yes. And doing that improves their outcomes overall. But what I think, we always talk about the outcomes of the infant when you use these meds during pregnancy. But if that child then gets to stay with you as the mom because you are in recovery, that is so much better for your child as well. So I think there's that, okay, now I'm my baby's delivered, so I'm on this medication. It's not going to help my baby. It's going to help your baby. Absolutely. It's going to help your baby because you get to have your baby with you and you get to be the parent you probably want to be. So I think there's that part of it that is very important and that people forget postpartum because they think, well, I've delivered now, it's too late, and that's not the case.
I completely agree. I have nothing to say beyond that. That's perfect.
Yeah, I'll just add a little bit is that unequivocally, yes, right? When we talk about what's best for baby in the postpartum time period, when you are looking at the spectrum of caregivers and parents, a caregiver or parent that is in active recovery is probably one of the most beneficial single things that we can think of for that newborn baby. Yeah. And we talked about how MAT is important and how it's the most life-saving treatment modality we have. And so fundamentally, starting even at delivery, before you leave the hospital, if you are alive, your baby is going to do better.
Yes.
So we talked about that overdose risk. I guarantee you, if you're dead, your baby will be worse off.
Yes.
So
I agree.
Yeah. One thing I want to make sure we get to from a medical perspective before sort of moving on to these like more patient-related fears and misconceptions. Dr. Iriye, can you tell us what does the pregnancy look like from a monitoring standpoint? What are you all doing during pregnancy for those individuals?
I don't think it's much different, right? I think it's different in the way of kind of overwatch. And I'm talking overwatch in terms of kind of usual things that we would do, like ultrasound. We'll probably do a little bit more ultrasound because we want to make sure that the person isn't having any problems with growth. So we want to look at the baby's weight every 4 weeks, later in the pregnancy. We want to look for abnormalities. We rarely find them, but we want to look for them because we want to make sure that we're telling the patient everything that we can in terms of the heart or other body parts. And then it's kind of getting into the program, right? And what does that entail? That entails, our therapist that's with us, social work if needed, which I think is so important. And me, like most doctors, I underestimated that until recently, until we had a social worker. I just really underestimated that and started screening for that. And then I think, it's kind of getting on a medication or a dosage that stabilizes you, but not only stabilizes you from the perspective of what we think, stabilizes you from what the person would think, right? Like, what's the best dose for me too? Because I think that's super important. So not a lot of major differences, but kind of, and it also would matter, I guess, a little bit on what was the drug or of use beforehand. If it was something that was IV drugs, et cetera, we'd want to look for, disorders such as HIV or hepatitis that could be associated with it. That would be important to know for time of birth. We do run screens when people show up, but they're not screens to say like, oh my God, what's going on with you? They're screens to say like, how can we help you? Like, hey, you had a slip up this week. How can we make you not slip up next time? What was the stress that was going on? What can we do to make things better? Did you slip up because your medication's not high enough and we need to get you on a dose where you're more controlled? I mean, these are the things that I think are super important. Yes. Or did you use something else that's not on the opioid pathway, that might be mixed in something? So we could talk to you about like, hey, there might not be any problems with the opioids, but there might be a little bit more issue with this that we need to watch, and let me tell you why, and let's talk about this. So.
I love it.
And what I really like about what you mentioned, Dr. Iriye, is this. We don't really need to do anything all that special. And that is fundamentally important, right? because I think that's a testament to how safe these medications are and how effective they are, such that someone who's stabilized on them, you don't need all this, oh my gosh, we need you coming in every
Extra,
other day
yes.
for monitoring and the baby this. It's relatively hands off. And that's because these things are amazing. I call them miracles of modern medicine. Yeah, medications
it.
like methadone and buprenorphine, et cetera. Okay, thank you. Thank you for sort of going into that. I want to lean on now, Amani, to sort of hopefully bring that patient perspective side of things so that while we have you in your time to answer, Amani, can you think of any sort of fears, misconceptions, concerns that you may have had yourself at some point or that you see in the patients that we have?
You know what? Both doctors were so very thorough that a lot of the things that I was thinking were answered. A major concern, I know a lot of people, first of all, want to keep it secret. They don't want any of their information getting out. And so I love how you addressed how your medicine, it's your information, HIPAA, right? Yeah. So I love that. I know that a lot of the times I've heard, well, I just want to quit and I don't want to be on medicine. Medicine sometimes makes me feel like I'm weak or I can't do it. I've heard that a lot. And I mean, just from what you guys said, it's not a sign of weakness. It's a sign of getting the help that you need so that your kid can have the best life that they enjoy, because a dead parent is not a great parent at all. So that does, that were really my two big concerns. And then also about how I did want to ask about, you had mentioned a third medicine. It started with a T.
A naltrexone.
A naltrexone? Okay. Is that new?
Sure.
Is that is something that's easily accessible? And
Yeah, okay. One concern that you brought up that I want Dr. Iriye to speak about specifically is this: I don't want to be on something maybe forever, or maybe only for a certain amount of time. Dr. Iriye, can you talk about duration of treatment and maybe what's some evidence that we see about folks who stabilize on medications and then come off of them when other things look really good, and how do they do?
Yes. And
I think the standard of care is to get people on a dose that they're comfortable with from a symptom perspective. There is some data out there that shows that if people do want to decrease their dosage during pregnancy, that there's two different groups. There's a group that really has a high relapse rate when they do that, and there's a group that doesn't have a high relapse rate when they do that. And the group that doesn't have the high relapse rate is in a program that is getting therapy. So that, again, just goes and shows the overall kind of treatment needed. And the rates are really high. I mean, the rates of recurrence or recidivism is the other word for it, when somebody stops without a program, is over 80%. But if they stop within a program, that's a really kind of all-encompassing program. It's more towards like 20%. And 20% still seems high, but it's really not.
No.
Just think of somebody trying to stop cigarettes on their own. How many times does it take them to stop? It's usually the fifth try, right?
Never knew that.
Yeah, so you really need to get to a point where we get rid of that stigma associated with it, and then come down at a rate that's good for you. Can people come down during pregnancy? Yes, but that's not really what most people do as standard, but it can be effective. But it has to be done in the confines of a really kind of well-rounded program.
And I wanted to know also, because I know sometimes you get caught up in the facade that, yeah, things are great, but we know it's the medication working. As doctors, how do you basically decide, like, well, no, let's give this medicine some more time in your system to really do its job before we tear you down? Or let's tear you down, or no, let's stay on the medication for much longer? How do you gauge things like that?
Do you want to take
First, it's almost always patient driven.
Got you.
I am not going to. I'm not saying I would never bring it up, but if a patient is doing very well on their current dose, and they're living their best life, right? They're in recovery. They have a job. They have a place to live. They're doing great. They're raising their child, and they're doing fantastic. If they feel really good, on this medication and they're not even thinking about decreasing their dose, that's not something I'm typically, bringing up with them because it's not a medication that you have to get off of.
Got you.
Okay. But if a patient comes to me and says, hey, Dr. Kamyar, I'm really interested in decreasing my dose and maybe even being off of it completely, I will look at that patient's whole picture. So is that patient stable from a standpoint of housing? Is that patient stable from they're living independently? Is that patient stable from a mental health standpoint, right? Are they participating in the program? Or are they not at all, right? All of those things. And that doesn't even mean that, say none of those things are true. It doesn't mean I wouldn't help them decrease their dose if they really felt strongly that's what they wanted to do. But I would talk to them about all of those things. I think I've said this before, but I compare it to diabetes. We always bring it back to diabetes. I think just because it's a very common thing that people know about. If you're a diabetic and your blood sugar is really, really high, let's say it's 400 all the time. That's really high, okay? And I need to give you insulin right now to bring it down so that you can live your life. So I'm going to give you insulin, and you're going to say, I don't want to. If I start this insulin, I'm going to need to be on it for the rest of my life. I mean, maybe, but let's start it. Let's get you healthy, right? Let's make your blood sugar normal. You're going to feel way better, okay? You're going to feel like you can live your kind of like walk around and live a normal life. So you're going to do that. And then I'm going to say to you, okay, Amani, well, now your blood sugar is normal and you can like think straight. So why don't we talk about how you can use some diet and some exercise and all these other things, right? So if you compare that to MAT, it's like, okay, let's get you on the buprenorphine so that you don't feel like you need to use opiates anymore. So let's get you there. Now that you're on opiates, now that your head's on straight, sort of, okay, what are these other things that you need? Well, you don't need diet and exercise, well, although those things are very good for everybody in general. But what you need is maybe, you need, like I've said before, transportation. You need a support system around you. You need a place to live. You need a therapist to talk about your PTSD from your past. Those are those things. And then when we get all those things taken care of for a diabetic, so let's say the diabetic does diet and exercise and they lose 100 pounds. They probably don't need their insulin anymore. So similar type of thing. I would probably be decreasing their insulin because if they keep taking the same amount, they're going to say, oh, this is too much, right? I don't need it. So it's the same kind of thing with buprenorphine.
I also think, and that's so great, right? Like, and I think that's like the perfect way to talk about it because it's kind of an evolution of the process and the disease, and you have to look at it. I wanted to bring up though the other side of it, right? I wanted to bring up the side of, I think it's also important to possibly see somebody, if possible for you, that has expertise in pregnancy with these medications. And the reason is because what we also see a lot is like out there in the older kind of science literature, it's stated, oh, you have to increase these medications during pregnancy. And you have to increase them. And the reason why is because outside of pregnancy, you have 5 liters of blood in your body. At about 28 weeks or 7 months, you have 8 liters of blood in your body. So the thought was, you're putting the same amount of medication into a bigger swimming pool, so the concentration is less, right? So you have to increase the meds. And so people are really looking for those symptoms of withdrawal, all right? And some of those ones are nausea. Well, what's common in pregnancy? Nausea, right? So we'll see people that get started on medications and really bumped up in the first trimester because they think that their nausea is a sign of withdrawal, and it's not. And so, we have those levers to be able to say, well, will this medication work? Can we change your eating patterns to see where it's going to happen? But, if you have to be increased, sure, you have to be increased. But I think it has to be done in a context of, like, hey, there's providers that can take care of pregnancy-associated things too.
Love it.
To help you from not going kind of further than maybe you want to go, but at the same time being where you need to be.
That is great.
Yeah. What's my one-liner when it comes to something like buprenorphine, these medications, right? And when folks are concerned, using sort of this motivational interviewing style, you ultimately get to make the decision. What are the pros and cons? What do you feel like you want to do? But when you're asking how long, I always say, as long as you need. As long as you lean. Hopefully these medications help folks because that's what we see.
Yeah.
Get to the point where they are living the life that they want to live. That's my tagline. Let's get you to the place where you're living the life you want to live, and then open discussions. We will do whatever it is that you want to do. Yeah,
I love it.
You want to come off of them? I'm going to make sure you're comfortable when coming off. I will not just discontinue outright. That's probably not going to go ideally, but we will absolutely have that discussion and absolutely navigate what that looks like to get you off medications if that's truly what you want. And you find folks across the board, folks that are like, I ain't changing a thing. My life is the most amazing it's been in 15 years. When I feel something, I will bring it up. And I'm like, okay, cool. I'm not going to bug you about getting off medication. You bring it up when you want. So there it is. That's sort of my tagline. We're going to close out soon because we're running out of time. But I want to make sure we get to your question. You had mentioned the naltrexone.
Yes.
Yeah? Okay, so naltrexone, the third FDA-approved medication for opioid use disorder. During pregnancy, Dr. Iriye, I know you have familiarity with naltrexone. Comments?
I mean, I think it's for somebody that wants to be off medications. Naltrexone can be a good kind of bridge to that in the future. And the reason is because that also attaches to that receptor and makes it so you can't use medications again. So just as Manijeh was saying earlier about, hey, this blocks issues with problems, how buprenorphine does that, naltrexone does that too. So I feel that it's going to be a medication, like you say, that's going to be thought of as really safe. I know some people in programs that when they do wean people off completely, they'll start naltrexone as an option. I think that's a really, really good one because what you don't want to do is kind of create that environment where you can take medications again and get these certain positive influences from them or what you feel are positive influences from that. We really know that aren't positive influences.
Yes.
But so again, a great option. I think that's somewhere that, there's going to be more study on that in the future and looking at programs that do that a little bit more. But every option that we have in our arsenal to make things better is great.
Yeah, I hope we get there as well. Fundamentally speaking, we talked about buprenorphine and methadone attaching to the opioid receptor and having some properties of activating. Naltrexone was a complete blocker. It's a complete antagonist. I'm throwing up air quotes. I want you to think of it as this. You know Narcan that we use to reverse opioid overdoses? It is simply long-acting, stronger Narcan.
Love it.
There it is. So what's really cool is it comes in an injectable form, so you get an injection once a month. It's effectively like having Narcan on board all the time. So think about how awesome that can be. Think about how protective that can be. And what I really like about pregnancy is there's essentially zero risk. Let's not say zero, but let's say there's essentially zero risk of the baby having withdrawal symptoms.
Love it.
And that is super cool.
Yes, that is.
Can we go back to that though? I mean, because we've talked about how buprenorphine we believe is better, but we haven't talked about why we think it's better.
All right, okay, close us out,
That
Dr.
was
Iriye.
gonna be-
Close us out.
Got to, well, anybody kind of add in, like, because I'm not going to cover it all, I'm sure. But, one of the major things is buprenorphine doesn't cross the placenta as well as methadone does. So you get maybe a 50% crossing of the placenta, 50 to 60%. So the effects on the baby are less. And then you get what's called this neonatal abstinence syndrome or neonatal opiate withdrawal syndrome. That becomes much less in people that take buprenorphine. And the key thing about that is those babies that get neonatal opioid withdrawal syndrome, they have a much longer stay in the intensive care unit. They have problems with irritability, feeding, et cetera. But also, I think the really, really super important evidence is there's studies that show that kids that get that have smaller brains and smaller brain volumes and have higher problems with motor skills or movement and learning disabilities later in life if they get that. So that's why we really favor buprenorphine if possible, because, nobody wants to have that happen if they can avoid it.
Yes.
But the thing is methadone is still good because, hey, if it's going to prevent overdose, it's going to prevent these other things, and it's going to provide a clarity, a decreased stress, which can cause preterm birth, growth problems. Hey, that's super important still. But there's just a reason why we think that buprenorphine's slightly better.
Yeah, and pivotal studies have been done, and they've shown that when you compare the two, buprenorphine has less incidence of withdrawal, less severity of withdrawal, and less duration of withdrawal. So significantly favorable profile when it comes to just withdrawal for the baby.
Yes.
And when Dr. Iriye mentions that if you get that withdrawal, then there's brain issues down the line, we effectively like to provide options that will keep mom alive, keep baby alive, and be better for both.
Yes.
There you go.
And I just want to put out there, because we're talking about the risks with these medications, but these same risks exist when you use opiates.
Correct.
So it's not that the medications, oh, okay, so if you use opiates, none of those things will happen. If you use heroin, those no, that I want to be clear. Those things are happening with the use of opiates, but we're going to have better outcomes with methadone over the use of like heroin or illicit opiates, and even better, side effects with buprenorphine use. So just wanted to put that out there, because I think some people might think, you only have these because you use the medications.
Yes.
That's not true.
Super important.
Correct. Let's close with this, then I'll have Amani. You can close this out. These medications are through and through better in every which way than illicit substances in the world.
Yes.
Done.
Yes. My dad always says, at least you know what it's made in the lab and you know what's in it. That, things that are on the streets, you have no clue what's in it. You don't know. You think you're buying heroin, you're getting fentanyl.
And methamphetamine.
Yeah, I was just, yep. So, yes, you are right.
Yeah.
Thank you guys so much. Thank you, Dr. Iriye and Dr. Farzad, for joining us today. And thank you, Dr.
Kamyar.
Yes, MJ.
Okay.
Guys, like
There's too many Kamyars. It's fine. There's one too many Kamyars. We're going to kick them out.
No problem. It was a pleasure being here.
It's going to be the me and Amani show.
Yes, yes.
You still have a cameo.
Yes. Thank you for joining us today on Empowered Voices and for sharing your great wealth of knowledge. You've definitely informed me on tons of great different things. I know you've definitely informed the audience. We thank you all for listening and watching this episode of Empowered Voices. Be sure to subscribe wherever you get your podcasts, as another episode drops in 2 weeks. Also, don't forget to rate and share with others who may find our information and discussion topics helpful. We encourage you to visit our website, empowermoms.org, to share your thoughts on this episode or suggest topics you'd like to hear more about. Thank you.
Thanks.
Thank
Thanks.
you.
Appreciate you.
Appreciate it.
If you live in Southern Nevada or in Reno, Carson City, Churchill County, or Lyon County in Northern Nevada, or in Weber County or Davis County in Utah, and you're pregnant or recently had a baby and using opioids or stimulants for any reason, there is non-judgmental help available to you. No referral or insurance required. Visit empoweredmoms.org for information or to request services. If you live outside of these areas, we encourage you to find resources in your community.
Empowered Voices is a podcast production of the Empowered program at Roseman University College of Medicine, supported by the Centers for Disease Control and Prevention's Overdose Data to Action grant through the Southern Nevada Health District. This project has been funded by grant number NH28CE003534 from the Centers for Disease Control and Prevention. The contents are those of the authors and do not necessarily represent the official views of, nor an endorsement by the Southern Nevada Health District, CDC, or the U.S. government. Hosted by myself, Dr. Farzad Kamyar, and Amani Wilson. Executive producers are Dr. Andrea Peterson and Jason Raw, with production assistance by Rachel Mack. Recorded at the Video Podcast Studio in Las Vegas, Nevada. For information about this podcast and past and future episodes, visit empoweredmoms.org.